Hi guys, good evening.
Good evening, sir.
Good evening, guys, and I'm so sorry, आज late हो गया. Today we are
It's
too late
okay,
actually.
sir.
Yeah, and some people have tried some mischievous act, you know, today with me, some scammers. So I was in the cyber police the whole almost half of the day, and I couldn't take the class. Okay, but it's okay. Everything is perfectly fine and all good. Shall we start? Yes. Now, so it's a relaxing time though. I mean, it's quite late, but relaxing time. I have no more classes. I am done with all the classes for today, and this is the last class for me. I can take, for the good time. So let me just adjust the things, guys, for you. Yeah. So yeah, let's start.
Sir, sorry, sir. I was not able to join the last meeting. I was outside that time.
No worries, it's okay. No worries, it's perfectly fine. We have shared the recordings, and I'll be share the recordings every after every class in 1 or 2 days. Usually, you get the recordings. Don't worry. So today is a very specific class. Very specific means very technical and very important though, because today we are going to talk about cardiovascular risk assessment. Okay, let me share the screen so you will understand this. What exactly the thing I'm talking about, right? I hope you get it. You got the slides. Is it
Yes,
visible?
sir.
Okay, perfect. Perfectly fine. Yeah. So now we can start. So today we are talking about the cardiovascular risk assessment, right? So we are discussing about first few things, because I don't think we can complete all things in one day. And why it is because one important part here is we cannot complete all these things in one day. We cannot complete all these things in one day because if we go into the risk scoring systems, it takes a lot of time. Okay, it will take a lot of time. And I want you to understand each and every aspect of these things. Okay, each and every aspect. So first, let's talk about the risk factors that we have already, studied. A little more addition to that. So there are some key risk factors modifiable. You know that we talked about hypertension, there is high blood pressure, there is smoking, right? There is smoking, hypertension, smoking, diabetes mellitus, dyslipidemia, obesity, sedentary lifestyle, poor diet, excessive alcohol consumption. This is the modifiable risk factors we talked about, right? And then non-modifiable risk factors in last class, like we cannot avoid and we cannot modify age, we cannot modify gender, we cannot modify the family history of CVD, ethnicity or race, we call it. These are some non-modifiable risk factors. These are the risk factors for the cardiovascular diseases. Usually people, if they are in the older age, if they have the male gender, or if their family first degree relatives have the history of cardiovascular disease like heart attack or stroke or something, they can easily get the cardiovascular problems, right? And in modified risk factors, again, you know that hypertension, smoking, diabetes, dyslipidemia, alcohol consumption, these are the major risk factors for cardiovascular diseases. And but these we can modify easily, but now today's addition, something I have added to these key risk factor is emerging risk factors. Okay, emerging risk factors. These are the major emerging risk factors nowadays. Okay, first is chronic kidney disease. Chronic kidney disease, when there is kidney insufficiency, or we call it renal insufficiency. Okay, renal insufficiency, that means the kidneys are not working well. Either, actually, acute kidney disease does not impact this much. If it is like acute kidney disease and being treated immediately, that doesn't matter much into the cardiovascular risks. But if it is a chronic kidney disease, then definitely, definitely it impacts the balances. It impacts the balances of electrolytes, right? It imbalances the electrolytes in the blood flow, and those electrolytes impact the muscle mass and the muscle activities in the heart muscles activity, cardiac muscles activity, and that can lead to not only one this thing like only the electrolytes, but other toxins also. Because of the chronic kidney disease, there are no proper elimination of all the toxins from the body, right? Those toxins also are directly related to that, and like renin angiotensin system, that can lead to hypertension, that can lead to other problems, so those like hypertension and all, aldosterone system is affected, as I told in the first class also. RAS system, RAS, renin angiotensin aldosterone system, that is also being affected, right? So chronic kidney disease is now one of the emerging risk factor for the cardiovascular diseases, right? For the cardiovascular diseases. And there is something called elevated high sensitivity C-reactive protein. Can someone tell me what is the use of elevated, or what is the use of high sensitive HSCRP, right? What is the use of HSCRP? Why we do it? Why the HSCRP is being used? Can someone tell me? Yes, guys, make it interactive. What is HSCRP? And why I'm telling you as a emerging risk factor, as an emerging risk factors now. Tell me, what is HSCRP? Yes, guys. Anyone? You know HSCRP, you don't know? To assess the damage to myocardium. Yes. Nimra, yes. Inflammation. Inflammation of muscles. Okay, inflammation of nerves. Inflammation, it could be because of, usually it happens because of what? I'll correlate it and you also can correlate it. Why we are focusing and it is in trend. HSCRP, why HSCRP is in the trend is majorly after COVID-19 infection. Okay, after COVID-19 infection, the inflammation in the body is usually increased, and this has lead to the muscular damage, cardiac muscular damage, myocardium, or like myocardium, the muscles of the heart, right? So heart muscle damage is provoked after the inflammation which was caused by COVID-19. Okay, and it is leading to the major CVDs and strokes. Okay, it is leading to the major CVDs and strokes. You must have seen that after COVID, heart attack rates have been increased and stroke rate have been increased. Thrombolytic problems have been increased, like hemorrhagic strokes and all, right? Deep vein thrombosis and all. Because HSCRP is one of the biomarker and one of the protein which increases in inflammation, and that is the major reason for cardiovascular problems. And it is now being considered as emerging risk factors for cardiovascular problems. It has been considered now as an emerging risk factors for cardiovascular problems, guys. Okay, what is emerging is like elevated high sensitivity reactant at HSCRP is one of the emerging risk factor. Then lipoprotein A. What is lipoprotein A, guys? Yes,
Actually,
lipoprotein.
lipoprotein is used. It is elevated in case of hyperlipidemia, and it is combination of lipid plus protein.
Yes. Okay, so lipoprotein A is also one of the major risk factor nowadays, guys. One of the major risk factor. And why I'm getting these things? Yes, helps in diagnostic familial hypercholesteremia. That's okay, familial hypercholesteremia. Or see, in the people, who are on the junk foods, let me tell you, familial and people who are chronically on the junk foods and who are chronically stressed, or let me tell you what are the major reasons for increased lipoprotein A, because I'm working on the lipoprotein A clinical trials. Okay, so first reason is familial, not much that. Number two is chronic bad food habits. I will write bad food habits. Okay, that applies on me also sometimes, but chronic bad food habits. And the third thing is chronic stress and the sedentary lifestyle. Okay, this goes with everything actually, but lipoprotein A has been seen increased associated with these four factors, because these four factors have been directly associated with VLDL and LDL raise, LDL increment in the body. You know what is LDL and VLDL? LDL is nothing but the low density, yes, low density lipids. Okay,
Lipoprotein.
low density lipoproteins, and low density lipoprotein, and VLDL is very low density lipoproteins. Okay, so these things are increasing day by day, and there is one specific markers which has come to the existence, that is lipoprotein A. Lipoprotein A is nowadays one of the emerging risk factors for cardiovascular diseases. Okay, and many papers, many things have suggested that lipoprotein could be one of the best biomarker nowadays for cardiovascular disease. Then metabolic syndromes like obesity and thyroid and some other problems. Diabetes is one of them. Diabetes is directly correlated and it's proven. But there are other metabolic syndromes, and metabolic syndrome is directly associated with cardiovascular diseases that we'll see one by one in the classes. And then psychological distress, psychological stress and depression, sedentary lifestyle. These are also one of the emerging risk factors nowadays. See, these are proven, and we know for longer time obesity, dyslipidemia, diabetes, smoking, hypertension are associated. But we can now say there are some more factors which are directly associated with cardiovascular disease risk. Okay, these things. Now, guys, next part, if you see, I have got this data from one of the very famous one of the very famous journal from American Heart Association. Okay, and this says, this is proven. Look at this data. Look at this data. See, hypertension is associated or increasing the cardiovascular risk by 30 to 35%. Your high blood pressure can increase your risk of heart attack or cardiovascular problems by 30 to 35%. And the second thing is poor diet. Can you see that? It is proven. This is the data taken from one of the very important and big journal of cardiovascular health. Okay, and you will see poor diet is associated with 20 to 30% of increased risk. And then obesity, 20 to 30%, smoking, 15 to 20%, diabetes, 10 to 15%, dyslipidemia, again, 15 to 25%, excessive alcohol consumption, 5 to 10%. Right? So these are the well proven risk factors which are directly associated with increased risk. And here you can see even the percentage of the risk which is increased. Hypertension means almost 35% of the people, 35 out of the 100 people are prone to get cardiovascular problems. Similarly, 25% who has dyslipidemia are supposed to get, 15 to 25 are supposed to get heart attacks or cardiovascular problems. Similarly, with the poor diet, 20 to 30%. And so this is very alarming issue, and these things are very important issues to talk about or to tackle, right? So this is one of the important part of preventive cardiology. When we try to talk on preventive cardiology, risk factors are important, and to study the risk factors in deep, what is the epidemiology, how much they contribute, how we can prevent them, how we can diagnose them, what is the mechanism of action, what is the pathophysiology, everything is very, very important, right? That is all about preventive cardiology. So the key risk factors you have seen now. Now I'll come to the CVD risk scoring. CVD risk scoring. So can someone tell me how we go for the CVD risk scoring? Any names, anything? How do we score the CVD risk, guys? How do we score the CVD risks? If someone comes with the CVD, I mean, someone comes to you. Okay, let me take an example of mine. Okay, guys, let me take an example of mine. Or let me take the example of someone else. Okay. Suppose there is Mr. A. Mr. A aged I'll give you some reasonable examples where you can think of critically and you can understand. Mr. A with the age of just 48 years. Okay, 48 years. Mr. A, 48 years, obese. Okay, obese. His BMI is 31.5. Okay, but his running status means exercise running, is 10 kilometers per day on treadmill. Good food habits, good food habits, but 2 bags of alcohol every day, 2 bags of alcohol every day. So if this is the guy, he comes to the doctor or suppose a cardiologist with what? Just for a normal annual checkup, right? Normal annual checkup. And he wants to know about his CVD risk. How much CVD risk is there, or how much time is there to get a heart attack for him in percentage or whatever. So, what do you think? How do we do that? How do we do that, guys? Anyone, anything, what you will tell, I'll, listen. What is CVD risk scoring? Anyone?
Diet chart, amount of levels of carbohydrate, proteins, and glucose monitoring.
Maybe partially, but not exactly, not correct. I'll say risk scoring. Anyone else? See, this is simple thing. If I'm talking about risk scoring, if I am talking about risk scoring, there are some scores. There are some scores or scoring systems. Okay, there are some scoring systems which you will definitely like when I'm teaching you. Scoring systems, there are some scoring systems from the big societies or big countries. They have been developed for use, not cardiac output, Sudeshna, exactly not cardiac output. But when I'm talking risk scoring, not cardiac output, risk scoring, the cardiac output is a diagnosis. Okay, not the diagnosis. Based on the risk factors, you can score the person's risk of getting heart attack or risk of getting cardiovascular disease. Let me tell you, let me show you this. Okay, let me show you this. So first, let me tell you what are the risk scores. Okay, they just use the risks only. Yes, Framingham risk score is one of the majorly worldwidely used. Okay, so let me show you here. There are usually majorly 4 scoring systems which are being used for cardiovascular disease status risk scoring. Okay, first is Framingham risk score. Framingham risk score. Another one is Quisk, which is used or developed by UK, and Framingham is not exactly US. It was actually first used in Canada. Okay, AVC, ASVD, ASCVD risk, atherosclerotic cardiovascular disease risk calculator is there from US. Score 2 is there in Europe. But in India and everywhere in the world, Framingham scoring system works. Okay, everywhere Framingham risk score is standardized. Framingham scoring system is standardized. Why? Because Framingham story, if you don't, how many of you have heard of Framingham story? Framingham studies story. Yes, guys. No. Okay, let me tell you. So I will be teaching you the Framingham risk scoring system. Okay, Framingham risk scoring system. So first, let me tell you a background what exactly the Framingham is. Framingham actually was a town before freedom of USA. Okay, usually, I mean, now it's in a part of Canada, I believe. Yes. or maybe that was a part of Canada before. I mean, US and Canada was when it was not separated, and before independence of USA, and I think 1938 or 1940s. So that time, the scientists, not exactly, will not go to the dates, but I'll tell you the story behind. I forgot the dates. I'll tell you the correct story here. So what the scientists thought, okay, let's do one epidemiological study. What they thought is, let's go and do some registry type of study, epidemiological study, where we will be looking at the risk factors and their long term outcomes. Okay, they just started assessing the society, Framingham state. Okay, the city, I mean, they started observing the entire city for the risk factors. They enrolled everyone, I mean, the elder people, younger people, and they started following up their diet, their whatever they are doing. Okay, it is free. It is free, Shruti. It is free. And anyone can use it. I'll show you. I'll show you. Don't worry about that. So let me tell you the story first. So they started a study, first planned for 5 years, then it stretched to 10 years, then 20 years, and this study gone up to almost 55 years. You won't believe, 55 years. Okay. And in 55 years, they got, but this is one of the largest study in the world. This is one of the longest conducting study in the world till date. Okay. In that, they observed everything, the entire life of the person for the risk factors and cardiovascular outcomes, like their lifestyle, their food habits, their living habits, their traveling, their, you know, their smoking, social habits, everything they observed, and they analyzed the data in proportional to the outcomes. Outcome was the cardiac events, like, and then they came up with multiple great results. You must go and read about the Framingham study. Okay, you must go and Framingham registry or Framingham study you can keep, and you can read about it. It's a fantastic story, fantastic study also. So so you can understand, when someone is observed for the long life, or the entire life, almost 55 years. Okay, entire life they were observed, and then the researchers, I mean, even the researchers 3 generations have been, working on the Framingham studies. Many people who started the Framingham study died, and then their researchers and then their researchers have come and took care of Framingham study, and then they came up with some fantastic results, wonderful scoring systems, because they have observed the living people for the life up to their cardiac events and even after that. Okay, the study was a very long study and multi-dimensional study, and multi-objective study, multi-outcome study it was. Right. So Framingham is one of a big name, one of a big, has one of the what we say big place in research. So you must read about Framingham. So this Framingham risk score is given by them only. Okay, based on their studies and all, they came up with the risk factors. Okay, they came up with the risk factors. Let me tell you about the Framingham risk scoring. So, sorry, risk score. Framingham risk score is a widely used tool. Okay, Framingham risk score is a widely used tool to estimate the 10-year risk. Okay, they, after their results and all, they can completely came with many things, and they came up with this wonderful tool where they can tell your 10 years cardiovascular developing risk. They can tell you within 10 years what is the chance of developing the cardiovascular disease in you. Assessing your risk factors, guys, how fantastic. Assessing your risk factors only, they can tell you how much percentage of risk you are having to develop the cardiovascular disease like heart attack. Okay, and this is based on the data from the Framingham heart study, as I was telling you. You can just read about it, and it incorporates several key factors. So again, I'll ask you this question: can you tell me what could be the risk factors they have been used or they are using to check the risk score in Framingham? Yes, guys, again, the question is repeated. Same here. What are the factors or risk factors they are using to check the Framingham risk score? Yes, someone tell died last time. Anyone who wants to add it to this? Yes, people. Okay.
Lipid levels.
No, look at this. What are the parameters addressed in Framingham risk scoring? First thing is person's age. Okay. First thing is person's age, then gender, then their cholesterol levels, total cholesterol and HDL. Only total cholesterol and HDL. They don't count LDL. They don't take care of LDL because that is considered to be one of the direct indicator for cardiovascular risks. So based on the very normal risk factors, total cholesterol, high density lipoprotein cholesterol, and then systolic blood pressure, whether that is treated or untreated, whatever is the blood pressure that day. Okay, so treated or untreated blood pressure, then smoking status and diabetes status. Okay, they check, they will ask you the age, gender, total cholesterol, high density lipoprotein, SDL, systolic blood pressure, working state, I mean, sorry, smoking status and diabetes. Only a few basic things. So you can understand here what's, modifiable and modifiable. So modifiable is total cholesterol. I mean, I'll write M, modifiable, systolic blood pressure, modifiable, smoking, modifiable, and diabetes also modifiable. Hypertension also modifiable, right? And then age and sex are non-modifiable, right? Non-modifiable. So these are the risk factors which have been taken. Now, how they check the 10 years risk factors? They divide it into three levels. One is low risk, one is, I mean, intermediate risk, one is high risk. Okay, let me show you this. Yeah, here is the thing. So how they do it? Risk category. Based on Framingham risk score, individuals are stratified into low risk. If it is 10 less than 10%, okay. If the risk is less than 10% for 10 years risk factor, that is called as low risk. If the risk is 10 to 20% for 10 years to get CVD, that is called intermediate risk. And if the risk is very high, more than 20%, 10-year risk, that is called as high risk for cardiovascular disease. Okay, low risk, intermediate risk, high risk. Low risk means if the score says that risk is less than 10%. Score says the risk is less than 10%. That is called as low risk. Less than 10% for next 10 years. Okay, understand that? Very simple to understand. Low risk means, I mean, the less than 10% for next 10 years. The person has the chances of heart attack less than 10% in next 10 years. The person has chances of heart attack 10 to 20% in next 10 years. That is intermediate risk. The person has the risk of heart attack more than 20% in next 10 years. That is high risk. Okay, so let's see how they do it. Okay, let's see how they do it. See, so first of all, points. Let's understand the points, or we will understand the points later also. Let me do it a practical thing with you. Let me show you. Okay, let me show you how it looks like and how it works like. Okay, let me show you. So let me share the screen again. So you will understand that how it exactly works. I'll just try it here. Sorry, yeah. I'll just write here. Yeah. So Framingham risk scoring is usually developed by CCA. This is Canada. Okay, this is from Canada. Canadian Cardiovascular Society takes care of that. See, if you look at this Framingham risk score, it's free of cost. See, suppose let's check for our patient. Let's check it for our patient. What our patient was? Our patient was, if I remember, this guy was 48 year. Okay, let me just keep here 48 year, right? He was male. HDL was 32. Okay, this is not ml. Okay, this is not mg per dl. So it was 3.2. total cholesterol was 5.6 mmol. BP, systolic BP was 156, suppose. And if the BP treated, if the patient is on medicines or not. So let's take, suppose the patient is on medicines. Okay. Smoker, yes, patient was a smoker. Diabetes, patient was, I think, let's say no, yes, diabetes. And family history, okay, we don't know family history, I'll keep no. Okay, let's calculate. Let's calculate. The 10 years cardiovascular risk is 29.4%. That is high risk, and heart age is 80. You can understand here. See, you can understand here. 10-year cardiovascular risk is 29.4% high risk. Okay, what is high risk here? And so what we should do, if the high risk is there, then what we should do, initiate statin treatment. Okay, initiate statin treatment, consider treatments in strong and high dose. Okay, and consider add-on therapy if LDL is also more than more than 2 mmol per liter, or non-HDLC is less than, more than 2.6 mmol per liter, or apoptosin B, is more than 0.8 gram per liter. So in that conditions, you should also go for add-on therapies. Okay, intermediate, if Framingham risk score is 10 to 20 or 10 to 19, then again, you should go for a strong or moderate dose. And if it is somewhere less than, 3.5, then you can start with a normal statin dose. Okay, and if the score is low, less than 10 Framingham risk score, then definitely you don't need the statins, and additional therapy also is not required. Additional therapy is not required. So it is very easy to understand the Framingham score. Okay. Statin, like again, recommendations are there, right? So you can, easily check those things. You can easily check those things. Now, let me tell you, see, you just understood here. This is the digital format. This is the digital format, and you can check Framingham score easily just by keeping sex age email. But can someone tell me now? Can someone tell me based on that you can calculate the Framingham risk score by yourself? Can you tell me? Can someone tell me if you can calculate the Framingham risk score without this calculator, without online calculator? Can you do that? Can someone do that? This was the digital format, and now we are depending on the digital format. We don't know what exactly is. No. Okay, Dhanveen Sudar is telling yes, they can. Okay, fine, maybe you have studied that. Definitely it's a good thing. If you know how to calculate the Framingham risk score, it's a very good thing. Okay, ultimate thing. So now let me tell you all how we do that. Sir, first thing is age. Okay, first thing is age. So what are the scoring system? If your age is 20 to 34, they have divided into the gap of 5 years. If your age is like here, it is 20 to 34, usually it is 5 years. Okay, if it is 20 to 34, in man, the points is -9, and in women points are -7. Can you understand? They have scored, they have pointed in -9 and -7. If the age is 35 to 39, what is the point scoring? Point scoring is -4 for men, -3 for women, right? And 40 to 44, it is 0 for men and women both. 45 to 49, 3, 50 to 54, 6, 59 to 68, 60 to 64, 10, and 65 to 69. For men, it is 11. For women, it is higher side, 12. And from 70 to 74, for men, it is 12, and women, it is 14. And 75 to 79, it is 16. And, you can see the 16 and 13. 13 for men and 16 for women. Right? So, let me tell you the interpretation here, what exactly you can understand by this. See, in the young age, even Framingham, that time, there was no cardiovascular risk factor at this age. This age, it was completely safe. and it was given minus points. Because why given minus points? Why given minus points? Because see, if these people have some young diabetes or something also, that also will be, not telling about the 10 year there. That is also not the risk for heart attack or for the cardiovascular disease for 10 years in such people, young people, because they are young, and if there is any problem, they can easily take care of that. They can easily take care of that. A body can easily take care of that. Our physiology is like that, that we can easily take care of that. We don't have to worry in such ages about the problem if we have the young age. But nowadays, I think there is definitely a need to change the Framingham risk score and other risk scoring. We should come up with the new risk scorings because the scenario have changed. It is 50 years, 50, 60 years. So the scenario have changed, and we can usually see the young heart attacks or, young cardiovascular diseases, right? So if the age, okay, and that's why then they usually considered from 45 to 60, they considered the lesser score, and more than 60, definitely the higher score for the heart attacks, okay, or cardiovascular disease, right? This is about age. Next thing is total cholesterol. Gender is also there, male and female, that always come, okay. Then Framingham risk score. Cholesterol. See, cholesterol, now it is mg per day. Indian scenario I took cholesterol in Indian scenarios. If it is less than 160, so any age group, no scoring. Okay, it will be 0. If less than 160 for any age group, it will be 0. If the cholesterol total is 160 to 199, 40, sorry, so they have the 40 gap of 40 mg per dl. So if it is 160 to 199 in the age of 20 to 39, 20 to 39, what will be the score? For men it will be 4, for women it will be 4. Okay, usually it is same everywhere, like 40 to 49 33, 50 to 59 22, 60 to 9 69 11, 70 to 79 11. Why this is only 1 1 and not 4 4? Why at very young age it is 4 and elder age it is 1 scoring for 160 to 199? Because that is the body's need. Okay, in young age you need a little lower of the body fat, total cholesterol, little lower of the body fat. And in elder age, you need a little higher to compensate for the pathophysiology and for the thermodynamics or hemodynamics both. Understand that this is a concept. I'll take this in the class when I'll be talking about the hypercholesteremia and heart health. Okay, in upcoming classes, I'll talk about this. And look at this. If it is again 200 to 239, the age 20 to 29, the risk score is 88. And for the age 40 to 49, it is 66, 50 to 59, 44, 60 to 69, 22, and 70 to 79, 11. If it is 240 to 280, 11, 11, 8, 8, and 5, 5, 3, 3, 2, 2, right? And if it is more than 280, then for men and women it is 13, 10, 7, 4, and 2. Okay. So this is how the scoring system works. This is how the scoring system works. Now, HDL, for HDL also, it is similar for both sexes. It is similar. Okay. For more than 60, HDL, it is -1 because it is good fat, right? HDL is a good fat. So if it is more than 60, -1. If it is 50 to 59, 0. I mean, normal. If it is 40 to 49, 1. And if it is less than 40, the score for HDL is 2. Okay, score for HDL is 2. You have to read it again. You revise the class 1 or 2 times and then practice it. I will try. I'll tell you how to practice. We will practice also after this. I'm just telling you first. HDL, then systolic blood pressure. Systolic blood pressure, again, it goes with the very important to understand. It goes with the hypertension categories. Okay, it goes with the hypertension categories like less than 20, 0, normal blood pressure. Blood pressure category, I mean hypertension category, 1, or we can say it is normal, like 1, hypertension category 1. For untreated, it is 1. For treated, it is 3. If the after treatment also, see, you have to interpret also, you have to understand. If the score is like, if the blood pressure is 120 to 129, even after treatment, then definitely it is concerning. So score is high, points are high. 130 to 139, 2 for untreated if it is untreated. And if it is treated, even after treatment, it is 130 to 139, then the points will be 4. 140 to 59, 3, 5. 160, 4 for untreated and 6 for treated. 6 for treated. Okay. Then smoking, 0 for non-smoker in men, and smoker 4 for men. For women, it is 3, and non-smoker 0. Non-smoker 0 and smoker, it is 4 for men, because men are more prone to get heart attack. Again, I'm telling you. Okay. So non-smoker man 4, sorry, non-smoker man 0, and smoker man 4, smoker women 3. And then diabetes, it is, yes, if the diabetes is there, then score will be added 2 by itself. Okay. Now, what is the risk score? If now you have to sum all the points, you have to add all the points, whatever you got in last 6 domains, you have to add all those points. You have to add all those points. And based on that, if your total point is 0, then I mean less than 0 and minus, then your 10-year heart attack risk or cardiovascular risk is less than 1%. Okay. For men, it is less than 1%. For women, also less than 1%. If your total points is 0, then 1% for men, less than 1% for women. See, look at this. That's why it is very much proving, and you can understand that women are, less prone to get heart attack. They are less prone to get heart attack, right? And men are more prone to get heart attack, right? So this is one. If the score total point is 0, then man has 1% and women has less than 1%. If the score is 1, 1%, 1%, score is 2, 1%. So from score 1 to 4, the score is 1% for both man and female. I mean, male and female, the score or the risk, I mean, based on the score, if the score is 1 to 4 also, then the risk of cardiovascular diseases for next 10 years is 1%. Okay. If the score goes 5 or 6, then for men, the risk increases to 2%. And in women, if the score is 5, then risk is only 1%. If the score is 6, then it increases to 2, right? Not at 5. At 5, look at the difference. Here is the difference. For men, it is 2%. For women, it is 1%. Okay. And total points, if there are 7 points, then 3, 3, 8 points, 4, 4, and then 9.55, 10.66, 11.88, and 12 point. Look at this. 12 point, it increases. 12 point, the things the coin have ulta now. In the man, it is just 10%, but in women, it is 11%. And now the risk starts increasing in the women. Okay. Now the risk starts increasing in the women after the score crosses the 12. After the score crosses, guys, remember, this is very important fact I'm telling you. If the score increases more than 12, the risk factor, I mean, the risk increases in women. Okay, risk increases in women. Why it is? Because older women and women with some specific disease are more prone to get cardiovascular disease. That is very important to understand. See, in previously, until the score is 11, men are at the higher side of getting cardiovascular disease. But if the score crosses 12, then definitely the chances goes towards women. In the older age, women dies more than men because of heart attacks. Understand that men is lesser, but the mortality is higher in women because they are at the higher risk if they have any other risk. Okay, they are on the higher risk if they have any other risk factors in life. Okay, any other risk factors, usually more than 2. Okay, so in that case, their Framingham risk score increases and their chances of cardiovascular diseases increases. See, if the score is 30, look at this. Man has only 12% chances, a woman has 14%. If the risk score is 14, women has fixed, I mean, man has 16%, women has 17%. 20, 22, 25, 27, 30, more than 30, more than 30, 30. So If the score is more than 18, then definitely the percentage of cardiovascular risk is very, very high. Understand? Very, very high. So now you have to understand this. You have to just remember sometimes. That's all. Okay. Let me take a practical scenario here. Let me take a practical scenario here. Then you can understand. Let's understand this by a case. Okay. Our case, we'll take our friend A, 48 years, male, smoker, no diabetes, right? No diabetes. And HDL level were what? HDL level V, yeah. So in the Indian scenario, HDL level was 35 and total cholesterol was 202. Suppose 202. Hypertension, yes, it was non-treated. Yeah, sorry. Last slide, that is definitely non-treated hypertension, systolic blood pressure 132. Okay, sorry, 132. 132. Correct. So this is the status of that man. Now check what exactly the thing says. How exactly he is on the risk factor, because that shows high risk factor, right? Now look at the age. Age, the patient is 48 years. 48 years, man. Now, score is 3. Okay, score is 3. So I will write here. We should not forget 3 plus total cholesterol was how much? 201 maybe. So for man 48 years, the score is 6. Right? Score is 6. 201 or 202 was there. For that, he gets age is 48. So he gets 6 score. Okay, he gets 6 score. Understand? Then 3 plus 6, sorry, 3 plus 6, HDL was 35, so less than 40, score goes to 3 plus 6 plus 2, right? 3 plus 6 plus 2. And then now next goes the blood pressure, 3 plus 6 plus 2 plus, what is the blood pressure? 132 for man, which was treated, so score goes to 3. Treated or untreated? I think it was untreated, right? It was untreated, so score goes 1, not 3, 1. 3, 6, 2, 1. So 9, 12, 11 or 1, 12. Okay, 12. Now, smoking. Oh, yes, smoking was there. So 12 plus 4. Diabetes, no. So 0 plus 0. 12, 4. 16 plus 0. 16, I mean. 16 okay? Right? And then now, total points, if you look at this, total points, if you look at this, 16. 16 is 16 is high risk. 25 to 27%. I mean, sorry, 25% of the high risk because man, he has high risk 25%. So 25% according to the distribution is very high because less than 10 is 10% and 10 to 20% is 10 to 20% is 20%, sorry, intermediate, this is low risk, right? This is low risk, this is intermediate risk, more than 20% is high risk. So this patient is already high risk for Framingham score and for 10 years cardiovascular diseases. Understand, 10 years cardiovascular diseases. This is the scenario. You can practice it with one more case with you. You can definitely practice it by yourself. Okay. You can practice it by yourself. Okay, guys. So with that, I will take off for today's class. And in next class, we will talk about something more in risk assessment because this is very important. You have to be throughout in the risk assessment. Once we are throughout with the risk assessment and diagnostics, then we can go further in the prevention part. Understand? Okay. Any questions, guys? Any questions? Any questions, guys? Okay, I think no questions. Is it clear, guys? Did you understand this concept?
Yes, sir.
Great. Thank you. Great. Thank you, guys. Thank you very much. So next, we will come up with some more good topics and some more good scorings and all. So see you guys next week. Okay. Thank you very much and take care. Take care, guys. Bye-bye. Good night. Have a good night, guys. Yes, guys. Have a good night. Bye bye. Take care. We'll see you next week. Okay. Bye bye.